After the age of 70, many people believe that regular medical tests are always safe, that more testing automatically means better health. But what if one common test, a test doctors order every single day, can actually cause more harm than good in older adults? This is not speculation. This is not fear-mongering. And this is not advice from the internet. Over the past decade, several large medical reviews have quietly warned about routine screenings that become riskier as the body ages. Yet most seniors are never told this. Instead, they are told to be safe, to check everything, to trust that more tests always equal better outcomes. But aging bodies respond differently. Blood vessels become more fragile. Kidneys process contrast agents more slowly. And recovery from invasive procedures takes longer, sometimes much longer. In fact, a report published by the Journal of Geriatric Medicine found that adults over 70 are significantly more likely to experience complications from certain diagnostic tests than younger patients, even when no disease is found. And here is the most disturbing part. Many of these tests are still ordered out of habit, not necessity. Doctors follow guidelines written decades ago, guidelines based on middle-aged patients, not seniors in their 70s or 80s. This means a test that is considered routine at 50 may quietly increase the risk of stroke, kidney injury, infection, or permanent nerve damage after 70. In this video, we will reveal 5 medical tests that doctors themselves are increasingly cautious about recommending to older adults, and why. Some of them may surprise you. One of them is still performed millions of times every year, and one test is now avoided by many physicians for their own parents. Before you assume this does not apply to you, stay with us, because the first test on this list is often described as completely safe, and that description may be dangerously incomplete. The first test on this list is often presented as harmless, quick, routine, and necessary. It is imaging with contrast dye, commonly used in CT scans and some advanced X-rays. For younger patients, contrast agents usually pass through the body without issue. But after 70, the story can be very different. As we age, kidney function naturally declines, even in people who feel perfectly healthy, even in people with normal blood work. When contrast dye enters the bloodstream, it must be filtered out by the kidneys. In older adults, this process is slower and sometimes incomplete. A large clinical review published in Clinical Nephrology found that seniors over 70 were up to 3 times more likely to develop contrast-induced kidney injury compared to patients under 50. And here is the problem. Kidney damage caused by contrast dye is often silent. There may be no pain, no immediate warning signs, just a gradual loss of kidney, function that may never fully recover. In some cases, this damage triggers a cascade of complications: fluid retention, fatigue, confusion, and increased risk of hospitalization. What makes this even more concerning is how casually these scans are ordered. A minor fall, unexplained dizziness, mild abdominal discomfort. Out of caution, doctors order imaging, just to be sure. But many geriatric specialists now recommend a different approach: contrast only when the result will clearly change treatment decisions. In other words, if the scan will not directly alter care, the risk may outweigh the benefit. Some hospitals have already begun flagging contrast imaging for patients over 75, requiring additional approval before proceeding. Yet most patients are never told they can ask a simple question: is this scan possible without contrast? That one question alone can significantly reduce risk. And the next test on this list is even more common, and even more misunderstood. The second test many seniors undergo without hesitation is routine colon screening. For adults in their 50s and early 60s, colonoscopy has saved countless lives. There is no debate about that. But after the age of 70, the risk-benefit balance begins to change. Colonoscopies are not just camera tests. They require bowel preparation that aggressively dehydrates the body. They often involve sedation, and in some cases, tissue removal or biopsies. In older adults, dehydration alone can trigger dangerous drops in blood pressure, electrolyte imbalances, and acute kidney stress, especially in those who already take blood pressure or heart medications. According to a review in the American Journal of Gastroenterology, adults over 75 experienced significantly higher rates of complications, including bleeding, perforation of the bowel, and prolonged confusion after sedation. What many people do not realize is this: most colon cancers grow slowly, very slowly. In seniors with no symptoms and no history of polyps, the chance that a routine colonoscopy will extend life becomes much smaller, while the risk of harm becomes larger. This is why several medical organizations now recommend individualized screening rather than automatic testing after 70. Yet many patients continue to be scheduled out of habit. No one asked me my age. No one discussed alternatives. I thought I had no choice. But there are alternatives. Non-invasive stool tests can detect blood or abnormal DNA without sedation, dehydration, or procedural risk. For many seniors, these options offer meaningful protection with far less danger. The most important point is not to refuse testing blindly, but to question necessity. Ask, will this test change what we do next? What happens if we find something slow growing? Is there a safer option for my age? Because the next test on this list involves radiation, and the effects can linger far longer than most people realize. The third test many people over 70 are encouraged to take is repeated CT scans, especially of the chest, abdomen, or spine. CT scans are powerful tools. They can save lives in emergencies, but when used routinely, without a clear reason, they carry a hidden cost: radiation exposure. One CT scan can expose the body to the equivalent of hundreds of chest X-rays. In younger adults, the body often tolerates this stress. In older adults, the ability to repair cellular damage is much lower. According to data from the National Institutes of Health, repeated CT imaging increases cumulative radiation dose significantly, and the risk does not disappear with age. In fact, seniors are more vulnerable to radiation-related tissue damage because their cells divide more slowly and repair less efficiently. What makes this more concerning is how often CT scans are ordered just to be safe. Minor back pain, mild abdominal discomfort, nonspecific fatigue. Instead of careful monitoring, imaging is sometimes used as reassurance, even when symptoms are stable. But here is the uncomfortable truth. Many findings on CT scans in older adults are incidental. Benign cysts, age-related changes, harmless abnormalities. These findings often trigger more tests, more scans, more procedures, and each step adds risk without improving outcomes. Medical guidelines increasingly advise that imaging decisions in seniors should be based on how results will change treatment, not curiosity or routine. A simple question can prevent unnecessary exposure. If this scan shows something minor, will we act on it or just worry about it? Sometimes, careful observation is safer than aggressive investigation. And sometimes, the most dangerous tests are not the ones that hurt immediately, but the ones that quietly accumulate harm over time. The next test on our list is even more common, and often done automatically during annual checkups. The fourth test many people over 70 undergo every year without question is routine stress testing, especially treadmill or pharmacological cardiac stress tests. These tests are designed to detect serious heart problems. And in specific situations, they are extremely valuable. But when used as a blanket screening tool in older adults without symptoms, they can create more problems than solutions. For seniors with stable health and no chest pain, shortness of breath, or sudden changes in activity tolerance, stress tests often reveal false positives. According to research published in the Journal of the American College of Cardiology, false abnormal results are significantly more common in older patients, even when the heart is functioning well. What happens next is the real issue. An abnormal stress test often leads to invasive follow-up procedures, cardiac catheterization, contrast dye exposure, arterial punctures. These carry real risks: bleeding, kidney stress, infection, and complications from anesthesia. Ironically, many of these procedures end with the conclusion that no dangerous blockage exists. In other words, the test created the problem it was meant to prevent. Cardiology guidelines now emphasize a symptom-based approach for older adults. Tests should be driven by changes in daily function, not age alone. If someone can walk, climb stairs, and perform normal activities without limitation, aggressive cardiac testing may offer little benefit. A better question to ask is, has anything changed recently that suggests heart strain? If the answer is no, careful monitoring may be safer than testing. The heart does not always need to be challenged to prove it is healthy, especially later in life. Next, we'll discuss a test many seniors believe is harmless, one that is often ordered automatically, but can quietly disrupt balance, energy, and overall well-being. The fifth test on this list is one that almost everyone over 70 has experienced: routine blood testing panels ordered year after year. Blood tests feel harmless. A small needle, a few vials, nothing serious. But in older adults, frequent and broad testing can quietly create problems that did not exist before. As the body ages, normal laboratory ranges become less reliable. Small deviations are common. Mild abnormalities often reflect aging itself, not disease. Yet these numbers are frequently treated as warnings: a slightly low sodium level, a borderline thyroid value, a modest change in cholesterol. Each result may trigger medication changes, dose adjustments, or new prescriptions, sometimes without symptoms ever being present. According to a review in the Journal of General Internal Medicine, older adults are significantly more likely to experience harm from overcorrection of lab values than from the values themselves. One medication lowers sodium too much. Another affects blood pressure. A third causes dizziness, fatigue, or confusion. This cascade is known among geriatric specialists as over-medicalization, and it often begins with well-intentioned blood work. In seniors, the goal is not to perfect every number, but to preserve function, balance, and quality of life. Many experts now recommend targeted testing, not broad panels. Tests should answer a specific question, not search endlessly for minor deviations. A simple conversation can prevent unnecessary treatment. What problem are we trying to solve with this test? What symptoms are we treating, not just numbers? Sometimes, the most dangerous result is not what the test finds, but what it sets in motion. And the next test on our list is one many people assume is completely safe, yet it can directly increase the risk of falls, confusion, and injury. The sixth test many seniors undergo without hesitation is routine balance and neurological screening performed in a rushed or superficial way. On paper, these tests are meant to protect older adults, to identify fall risk, to detect neurological decline early. But when done without context, they can do the opposite. Simple balance tests, standing on one foot, walking heel to toe, following quick instructions, are often influenced by fatigue, anxiety, poor sleep, or unfamiliar surroundings. A single poor performance can be misinterpreted as decline. According to research published in Geriatric Neurology, false indicators of impairment are common when balance or cognitive screening is performed without repeat testing or proper conditions. And once a label is applied, it tends to stick. High fall risk, possible cognitive impairment, reduced coordination. These labels often lead to restrictions, reduced physical activity, unnecessary walking aids, increased fear of movement. Ironically, fear and inactivity are two of the strongest predictors of actual decline. When older adults are told to be careful too often, they move less. Muscles weaken. Balance worsens. What began as a precaution becomes a self-fulfilling cycle. Geriatric specialists now emphasize functional observation over isolated testing. How someone moves in daily life matters more than how they perform in a clinic hallway. A better approach is to ask, have there been real falls? Has daily function changed? Is confidence decreasing or just caution? Screening should guide support, not limit independence. The next test on our list is often overlooked entirely, yet it quietly affects memory, strength, and long-term health in older adults. The seventh test many people over 70 rarely question is routine hearing and vision screening without follow-up context. At first glance, these tests seem harmless. A chart on the wall, a pair of headphones, a few simple questions. But the problem is not the test itself. It is what often happens after. Small age-related changes are frequently labeled as deficits that must be corrected immediately. A slight reduction in hearing range. Mild vision changes that fluctuate day to day. According to research in the Journals of Gerontology, abrupt interventions, especially when not tailored to the individual, can increase confusion, headaches, dizziness, and even anxiety in older adults. For example, hearing aids prescribed too aggressively or adjusted improperly can overwhelm the brain. Instead of clarity, they introduce constant noise. This can worsen fatigue, irritability, and cognitive overload. Similarly, vision corrections that ignore balance and depth perception can subtly increase fall risk, especially in unfamiliar environments. What many people do not realize is that sensory systems adapt slowly with age. Sudden changes can be disruptive, not helpful. Geriatric specialists now recommend gradual adjustment and functional evaluation rather than immediate correction based on a single test. The most important question is not, what does the test show? But how is this person functioning day to day? Can they read comfortably? Navigate their home safely? Recognize faces and sounds without strain? If the answer is yes, aggressive intervention may do more harm than good. Testing should support adaptation, not force rapid change. And the next test on our list is one almost everyone assumes is essential. Yet its benefits after 70 are increasingly debated. The eighth test, often recommended automatically after 70, is routine bone density scanning without symptom-based context. Bone scans are meant to identify fracture risk, and in certain cases, they are extremely useful. But when performed routinely, without considering mobility, strength, or fall history, they can lead to unnecessary treatment and unnecessary fear. As bones age, density naturally decreases. A scan may label this change as osteopenia or early osteoporosis, even when a person has never fractured a bone and remains physically stable. According to research in Osteoporosis International, many older adults diagnosed through screening alone are prescribed medications that carry their own risks. Jaw problems, muscle pain, digestive issues, and, paradoxically, increased fracture risk after long-term use. What is often ignored is the most important predictor of fracture: falls, not scan results. Strong muscles, good balance, confident movement. These protect bones more effectively than numbers on a report. Geriatric experts increasingly recommend that bone scans be paired with functional assessment. How well does the person stand from a chair? How steady is their gait? Have there been real falls? Without this context, scans can shift focus away from what truly matters. Instead of building strength, people become afraid of movement. Instead of improving balance, they avoid activity. Bones do not break in isolation. They break when the body loses stability. The final test on our list is perhaps the most controversial, because it is deeply ingrained in preventive medicine, yet its value after 70 is now being carefully re-examined. The ninth and final test on this list is routine preventive screening, performed without considering life expectancy, function, or personal goals. This includes annual tests that are ordered automatically, not because something has changed, but because it's time again. Blood markers, cancer screenings, general checkups designed for middle-aged adults. For many people over 70, these tests no longer offer the same benefit they once did. According to guidance from the American Geriatric Society, preventive testing should shift focus later in life, from early detection at all costs to preserving function, independence, and comfort. The reason is simple. Some conditions progress slowly. Some treatments introduce more harm than benefit, and some findings lead to anxiety, procedures, and medications that never improve quality of life. This does not mean testing should stop. It means testing should become intentional. The most important question is no longer, what can we find? But, what will actually help this person live better? Good medicine after 70 is not about chasing numbers. It is about listening to the body, observing real changes, and making decisions that support strength, clarity, and independence. Doctors who specialize in aging now agree on one thing: the best care is personalized care. If you remember one message from this video, let it be this: you are allowed to ask questions, you are allowed to pause, and you are allowed to choose care that fits your life, not just a checklist. Knowledge is not about fear, it is about clarity. And clarity is one of the most powerful tools we have as we age,